Welcome, everyone, to today's webinar, which we've titled Mind the Gaps: International Medical Travel and Transitions of Care. Today, we'll be talking about a topic that, frankly, hasn't been talked about before, and that's the transitions of care for medical tourism, medical travelers. And with me today is Keith Pollard from many of you will know from IMTJ, the editor, and also a colleague in the international medical travel markets. A few points of order. I will be talking first about the problem and scale of the problem, then Keith will join us talking about anecdotes and storylines and narratives and what the issues are associated with these gaps in medical care. For those of you who are interested, this seminar or webinar is being recorded, and it will be available afterward if you were booked and you didn't make it, as often happens. And then also, if you have questions, and we hope that there are lots of questions, we think there should be. If you have questions, we hope that you will put them into the Q&A in the Zoom screen so that we can track the questions, and my colleague Emily Trask will be of assistance in that regard and will sum things up at the very end with some instructions. So I'd like to start, if I may, by just framing the issue. The topic, Mind the Gaps: International Medical Travel Transitions of Care, refers to those gaps that occur between the care being provided in a destination and when the consumer travels back to his or her home. So in this session, I hope we can cover the nature of the problem and talk about some estimates of the scale of the problem. What's the story? Some anecdotal evidence that these problems do exist and how they get identified in society and within healthcare systems, and then what some potential solutions might be to the problem that we see. Maybe you don't agree, but this is the first of a series of 4 programs being led by Project Red Solutions. Project Red Solutions is a research, training, and consulting organization that offers training and consulting in transitions of care, especially looking at one of the models of transitions in care called Project Red, and RED stands for Re-Engineered Discharge. And the series is listed here, and we'll remind you again of the series schedule as a save the date at the end of the program. So let's talk about what the problem is. What is the problem? Around 2.3, 2.4 million consumers travel every year across borders to consume medical services. Some people believe that number is significantly bigger. This is a very conservative frontline estimate. And this is to distinguish medical travel, that is to say, individuals who travel for secondary, tertiary, or quaternary care in another country. So they cross the border to consume care. In addition to that, there are roughly 250,000 to 500,000 individuals who travel across borders for cosmetic or lifestyle procedures, hair transplants, plastic surgery, and other lifestyle types of treatments. While these people travel, the attention in the medical tourism markets and the literature has focused on the nature of these individuals, where they're coming from, where they're going to, how much they're spending, but there's been very little attention paid to what happens when something goes wrong. I'm not necessarily talking about what happens if something goes wrong in the travel, but really what happens if something goes wrong in the treatment. What in medicine is referred to as an untoward outcome. We're going to talk about specific types of untoward outcomes called sentinel events. And if you assume that the rate of these sentinel events, which are serious events that threaten the well-being or the life of the consumer, that's the definition of a sentinel event. If you take a low, medium, and high rating of these. Here are the numbers on the screen. Using the estimates of the medical travel and health travel numbers across the planet, at the low level, there's 173,000, 175,000 sentinel events, averaging out to be something in the neighborhood of 450,000 of these sentinel events for medical travelers across the globe. Now, that's a significant number. If you parse these numbers out, and I'm building this model, I've built this model based on the best available data from the United States and the United Kingdom, where good records, good information is being stored and recorded on the nature of untoward medical outcomes in medical treatments. So these numbers are inferred to the overall group of medical travelers. So if you look at these still further, and here's the estimates of the problems of the sentinel events, if we assume that the care is as good elsewhere outside of the US and the UK as it is in the US and the UK, that would be the number of events that would be likely and predictably occurring in that traveling population. Now, many people will argue that the care outside of the US or the UK isn't as good as it might be in the US or the UK, but I put that aside for the moment and just used those estimates as a way to infer the global numbers. And if you look at the sentinel event by type, that there's three types. One is people die from these complications. People have to go back to the provider, and Keith is going to be talking a lot about that because there's some significant experience in the NHS of the UK about these events, or they need to be readmitted to the hospital. And as you can see from these numbers, these are substantial, being inferred from the total global traveling population. That's the outcomes of these sentinel events. These are very conservative estimates, and I would estimate the total value of the problem. That is, this is the cost of redos without calculating the cost of mortality. I'm not an insurance actuarial. There are numbers that would allow us to do that. But just the returning to the providers, going back to the doctor and saying, gee, this doesn't seem right, doc. What do you think about this? The costs associated with that, as well as hospital readmissions, for which we have good estimates both in the UK and the US, the cost of readmission is significant. It's a $1.4 billion problem, which, given the global scale of the medical travel markets, is roughly 20 to up to 27% of the value of the global market. So why focus on care transitions? Well, readmissions or hospital readmissions, which is an event we can actually monitor, measure, and examine. These readmissions may be the result of a clinical change in the consumer. The patient gets sicker or has another complication and returns to the hospital. It could be the result of poor quality treatment. Something wasn't done up to a standard of care in the destination provider. And then when the consumer returns, the consequences of that poor treatment are manifest in the patient needing to seek medical services. Or the individual who received the service wasn't engaged with the service, didn't understand what he or she needed to do in order to recover and heal correctly, that the individual took risks that weren't appropriate in his or her behavior. It could also be a systems error. So there's individual error and there's systems error. There could be procedural or process errors. And we'll drill down a little bit into this. It could be that the prescription was wrong, or that the instructions on how to care for the wound weren't quite correct. So these poor or unplanned transitions is really where we can address the opportunity for changing this system, addressing what needs to be addressed. The bottom line is that these poor and unplanned transitions put the patient at risk, put providers at risk, because who's going to go back to that hospital? Not every country in the world is as litigious as the United States, but it puts providers at risk, and it certainly wastes resources, wastes the consumer's resources, and it wastes the resources in the source country. So the problems are significant, and the research bears this out. Research in the US shows that at the time of discharge, almost a third of patients receive no verbal instruction about the new medications that they've been prescribed. Half are not told the reasons for the follow-up appointments that they are directed to accomplish. And as my colleague Brian Jack says, if you're sick enough to be in the hospital in the first place, you're certainly sick enough to have follow-up care. 55% are not given instructions on post-hospital disease self-management. And 81% of patients that were discharged didn't receive any instructions on red flag signs, what they need to look for that's exigent, that's important, that's significant. They need to go see the doctor right away if it happens. And here's what patients recall from being discharged from hospitals. Almost 40% did not recall the reason for their inpatient treatment. This blows my mind. So patients don't know why they were in the hospital, can't repeat why they were in the hospital in the first place. They can't say what their diagnosis is or was. They don't recall the treatment plan, and they don't recall the medications, the prescriptions that the doctor has suggested that they take. And follow-up care, even in the best of circumstances, follow-up care is unfinished business. Only 25% of discharged patients require additional outpatient workup, and over 30% of those are not completed. Amazing. Much of this is in the communications realm. Much of this has to do with communications. The discharge summary, so if you're in the hospital for a hip replacement or cosmetic surgery and then you're discharged, up to a third of the patients don't have their discharge summary available at the time of their post-discharge visit, and actually when they do have a post-discharge visit. And many more don't have their discharge summary at 4 weeks. And those discharge summaries that were looked at in these studies in the United States, they didn't include a tremendous amount of information that needs to be in the discharge plan in order to assure the greatest likelihood of a successful recovery, a successful post-hospital care period. Direct communication between the hospital that provided the care or the treatment and the post-acute caregivers occurs only a fraction of the time. This, ladies and gentlemen, is a very serious problem. Now, the question is, of course, are these better or worse than in medical travel? Based on my experience in the sector and in the markets, and based on my discussion with many people in the markets, it's probably significantly worse in the medical travel. So what is these solutions? What is the standard of care within the re-engineered discharge model that's proven in the United States to reduce readmissions and improve recovery rates? First is provide an after-hospital care that the patient can understand. There's a lot about patient engagement that's used as a calling cry, a banner to call for greater levels of engagement of patients in their own medical care. And certainly an after-hospital care plan that the patient understands seems to be the bedrock of this. Oh, and by the way, this list that I'm about to give you of the standards of care within the re-engineered discharge model is available at our website, projectredsolutions.com. The second is to have medication reconciliation and education. If the patient has been receiving her heart medicine based on a formulary in Switzerland, and the patient goes to Italy to receive care, to receive a valve transplant, and then goes back to Switzerland, are those formularies the same? Has anybody looked to see if the formularies are the same? The dosages and the exact compounds of the medicines are the same. That's critical. We need to create a follow-up plan for outstanding labs and tests, and a plan that's based on realistically what's available in the consumer's source location, or the location to which the consumer is returning. We, the providers, should be arranging appointments that the patient can keep. If the patient needs to have an appointment for surgical suture removal, we need to be actively involved in assuring that that appointment is made at a time, in a place that the patient can actually keep. We need to organize post-operative or post-discharge services and equipment. If the patient needs a supportive ambulatory device, can he get it? Does he know how to use it? We need to reconcile the discharge plan with any national or international guidelines. That alone is a very interesting topic. And in my next program, we'll be talking with the president of the Case Management Society of America about what that means. And then finally, we need to send the hospital or clinic providing the care should be sending the discharge summary to the consumer's primary care provider, PCP, within 2 days, realistically enabling the patient's doctor or patient care team to look at the information, and meaningful follow-up about no more than 2 days after the discharge. Now, the question is this being done in the cross-border trade in medical services, cross-border, the international medical tourism markets? I doubt it. In the interpersonal, educational, and behavioral domain, so the prior list was systems-based. In this domain, the question is, can the patient understand what he or she should be doing? So assess the patient understanding and arrange alternative if the patients don't understand. This is called teach back. It's a simple methodology, but it assures the patient, the consumer, understands what she needs to do in order to care for her wound, care for herself, that the family, if necessary, can accomplish and help the consumer in those regards. We need to determine the need for and provide language assistance if necessary, which is why that teach back part of point number 1 is so important. If the person doesn't understand, it doesn't help. Provide education about the diagnosis and what the likely trajectory or the likely pathway of the diagnosis is, and involve the family caregiver. If one is involved the family caregiver. Many of these consumers that are traveling, especially for tertiary and quaternary care, have an accompanied adult, and those individuals should understand what to look for and when to be concerned, and explain common problems and what to do when they arise. Those are the standards of care for a research-based, demonstrated procedure that can improve the outcomes of post-discharge period with consumers in the United States, anyhow. And these principles would have an enormous impact in the international trade and cross-border medical services. So this process, this re-engineered discharge, what can it do? It can, first of all, reduce the risks for patients and providers. It can preserve the reputation of providers and even of entire destinations. It definitely has been shown, the research has shown, that it improves patient satisfaction. It increases adherence to follow-up appointments and medications by focusing on them and sharing that focus before the patient leaves the clinic, leaves the hospital. You've created a certain intensity around this that the patient improves, pays attention, and improves adherence. It can reduce hospital readmissions by up to 20%. That's what the research says. And in the medical tourism, medical travel domain, it might even reduce hospitalization even further. It increases clinical staff efficiency and it lowers healthcare costs because it lowers the waste in the system. The Project Red solutions we're offering, and I hope you'll visit our website. It assures the consistent delivery of high quality discharges and transitions. It saves time and it connects patients to the post-discharge, post-acute navigation system, and it improves evidence-based interventions in the post-discharge period. It's a very quick overview of the scale of the problem. And now I'd like to pass the baton to my colleague, Keith Pollard, who will take it from here.
Thank you, Irving. Just share my screen. Good afternoon, evening, everyone, or morning, depending on what part of the world you're in. Irving's asked me to take you through some of the reasons why you get these issues of post-operative complication on discharge and so on. So I'm going to be talking about in medical travel, where and why things go wrong, what the consequences of that are for the provider, for the source country and for the destination country, how destinations have responded to this and what they're trying to do to fix the problem, and potentially some longer term potential solutions. So let's start with where and why things go wrong in medical travel, why people end up without the kind of outcome that they're selecting. And a way of looking at this is the overall patient journey. And things can go wrong or not be done right anywhere throughout this patient journey, that can affect what happens after the patient has gone home, so post-operatively. But let's step back before the consultation. And I just want to highlight one issue that arises. Here's a couple of adverts that have appeared on UK social media. They're promoting cosmetic surgery, they're promoting bariatric treatment and so on. They are very much an oversell of the experience that a patient can expect and potentially overselling the outcome. The other issue, of course, that they are misleading, but in the UK, you cannot post adverts like this within social media or in the national press. And in fact, both of these adverts were reported to the UK Advertising Standards Authority, and the providers have been sanctioned and the adverts have removed. So if you're in the business of targeting the UK or any other country, please ensure that you find out what the current advertising rules are and what you can and cannot say. And in your advertising, be realistic about what a patient can expect. So the issues can arise in terms of an oversell of what the patient might be looking forward to. The diagnosis may be wrong. The consultation, one of the criticism I hear about medical travel from patients where things have gone wrong is, well, I met with an agency, or I met with a representative of the hospital, but the first time I ever got to speak to the consultant or the surgeon who was going to do my operation was on the morning of the operation. And that, frankly, isn't good enough. That's not the way things should work. Things go wrong in terms of treatment because you may have a hospital, a clinic, or a surgeon who is not competent in terms of the type of operation that they're undertaking on a medical traveler. As Irving has talked through in detail, the discharge and the transfer to aftercare in the patient's own country is where it often goes wrong. The patient may be discharged far too early. They may not be advised what to expect in terms of aftercare, or may not be prepared to set up what is needed within their own country to get things sorted. So what are the consequences when things go wrong? What happens? Well, the worst case scenario, and I'm going to show you some examples of the UK media and how it's talking about medical tourism, because generally, if you go to most source countries, medical tourism has a pretty bad reputation. and pretty bad image when it comes to our national press and our TV. Here's the worst possible outcome. Here's a story of a Cheshire guy whose fiance has died in Turkey after weight loss surgery. And we'll come on to those kind of issues in a moment. So that's obviously a personal issue for that family, but that's significant reputational damage to Turkey as a destination. Here's another one. This is a Channel 5, one of the main TV stations in the UK. It runs a series called Botched Up Bodies, and inevitably, this doesn't just cover surgery that's gone wrong in the UK, but here's episode 2, which features this is cosmetic surgery that's gone wrong in, I think, Poland in this case, but it features various operations that have gone wrong for medical tourists, and then uses UK surgeons to fix the issue. Again, reputational damage and not promoting a positive image of medical tourism. The Daily Mirror, this is a national paper. Its target audience is ripe for medical tourism, but is this selling a positive news story? No, it's not. It's saying cosmetic surgery gone wrong abroad is costing the NHS 30 million per year. This was a couple of years ago. It's probably up to the £50 million mark now. And clearly this is not just an issue for countries like the UK. In any of the source countries for medical tourism, we see similar kind of horror stories in the national press about where things have gone wrong. And here's an example from the USA with cosmetic surgery. Irving will support the fact that this is not an uncommon press and news story in that country. Here's another one. South Korea is one of the most admired destinations in that part of the world for cosmetic surgery. But even so, where there is unlicensed practitioners undertaking cosmetic surgery, when things go wrong, then that's when the issues arise, and you get this kind of negative image in the media. So what was the response? How do people in the industry and in the healthcare sector respond to this? And there are some words of warning here. In the worst case scenario, if you're operating a hospital or you're a surgeon abroad, then things go wrong due to your incompetence or the failure to really kind of achieve a positive outcome, then you can be legally liable for that. It rarely succeeds in medical tourism because of the issue of legislation in one country, a patient traveling to another country, but it does happen. This was the first ever case in the UK back in 2012. And this was where an Italian surgeon in a Belgian cosmetic surgery clinic was treating an English patient, and lo and behold, the UK lawyers managed to succeed in a case in the UK courts because the Belgian clinic had offices and a presence in the UK and won a case against that clinic. So there are financial risks for those who get this wrong. The bigger issue is where the problem becomes so significant that governments begin to take action. I'm going to use the example of Turkey in my next few slides. I'm not taking a particular having a particular go at Turkey, but the reality is more Brits go to Turkey for things like cosmetic surgery and obesity surgery than anywhere else in Europe. So the more that go, there's more complications potentially can arise. And the issue with Turkey and UK patients going there has attracted the attention of the UK government. And here's a report just in November last year about the deaths of 22 Brits who have been to Turkey as medical tourists. So the UK government has actually taken action about this. The latest, to reinforce the kind of concerns, this is a research study that was published literally 2 days ago, and it assesses the costs of obesity surgery abroad to the UK NHS. And what they did in this study was the researchers looked at 5 London hospitals that are dealing with complications arising from UK citizens who've gone to Turkey and other countries for obesity surgery. And here's what they've just published. And what they've said is, in 2022, at the 5 hospitals that were studied, there were 35 patients who came back from abroad with problems, complications from bariatric surgery. The cost to the National Health Service was £16,000 per patient. That's a significant issue. How does the government respond? Well, interestingly, if you look at Google, on UK Google, and you do a search for Turkey medical tourism, below the sponsored results, what's the first result? It's the UK government's advice on traveling to Turkey about healthcare. And then if you click on that, you'll come to an extensive piece of information really saying this is why you should think twice about going to Turkey. Here are the issues that people are facing when they've gone there. So that's the UK government responding to this issue. In some parts of the UK, the reaction's been even stronger. This is the Scottish NHS. What we have here is this is a general practitioner who writes a column in one of the UK's national newspapers, and he writes here about his practice and what happens during the day. And he's saying he's got a letter from the Chief Medical Officer of Scotland reminding him as a GP that the NHS is not going to pay to fix any Scot who's gone abroad for medical tourism services to have an operation, who comes back and has an issue. So the Scottish National Health Service is not going to fix mistakes that have occurred, or maybe even possible, the complications that could be foreseen that have taken place abroad, and they're not going to pay. And the GP is to tell patients, if you have a complication, then you're going to have to pay privately. The NHS is not going to cover you for this. Of course, governments respond to this. So how do they respond? Well, again, taking this Turkey issue, because it is a big issue at the moment, Turkey obviously defends this and says, well, hang on. About 5 years ago, we introduced these significant standards to try and block this happening and stop this happening. And here we have, this is back in 2017, Turkey introduced a law that regulated hospitals, clinics that were treating international patients. It's certified fairly quickly, about 2,000 clinics, and theoretically there's an annual recertification. The issue is, and this, I was at a workshop in London a few weeks back, which was attended by about 30 Turkish hospitals and clinics that were looking at this issue. And their concern was that the government has issued the regulation, but it's not effectively implementing it. So to be certified is pretty straightforward. So what are the possible solutions to this? How do we overcome this? Is insurance the solution? Now, if you look back over the last 10, 15 years of the medical tourism sector, there have been a whole number of attempts to introduce forms of medical travel or medical tourism insurance that cover the issue. The problem has been that most of those companies have disappeared. They started to try to sell a product, but the patients themselves did not buy it. They weren't convinced of the risks, and they weren't prepared to spend another amount of money. Given they were traveling abroad to save money, they weren't prepared to buy insurance that would cover them for complications if they were abroad. This is a health insurance, complications insurance that is currently available within Turkey. And the way this is marketed, it is sold and marketed through the hospitals and clinics themselves. So Turkish government is encouraging the hospitals and clinics to build this kind of product into their medical tourism package. and that makes sense. However, my concern would be if you get into the terms of this complication insurance, what does it say? And here's a couple of answers to FAQs. Can I benefit from my insurance if complications occur after the operation? Answer, no. Does my insurance cover complications arising from doctor's error? No. So I suppose the question for me is, what exactly does it cover me for, and how is that reassuring patients about concerns they may have about traveling abroad? Another solution that a number of providers are coming up with is, well, we're going to discharge patients from our country. We're going to send them back to the UK or the USA or wherever they've come from. And one of the things we have there are local offices. And again, here's a couple of examples. This is Acıbadem's office, Turkish hospital provider, their office in London. Here we have on the right another one that's promoting a Turkish clinic, promoting their medical center in London in the next week or so. And I suppose the issue for me is that these offices are not about aftercare. What these offices are about marketing. So this is about how do we generate patients and get them to our country. And what we really need to see in medical tourism is offices in the local source markets that are there to ensure that once the patient returns home, the appropriate level of care is provided, that the patient is supported, and that any complications are dealt with effectively. Is there a better off, or is it about better aftercare? Let me just close by giving you an example of this is Nord Orthopedics. This is an orthopedic clinic in Lithuania, which has targeted the UK market and the Scandinavian markets. I believe currently something like 85% of its throughput of orthopedics is not Lithuanians. A significant number of Brits are going there. And what's interesting about this particular clinic, it's getting incredibly positive PR and media coverage in the UK press. It's regularly mentioned, as you can see from the various media outlets that are mentioned here. And I think one of the main reasons for this is kind of hidden way down the bottom. They're not just selling surgery, they're selling surgery and a rehabilitation and aftercare package. And they're presenting the arguments as to why you don't fly to Lithuania, have an operation, and then we ship you home. Their argument is you stay 7 to 10 days in Lithuania. You are referred out to a medical spa or rehabilitation clinic. And by that method, we will assure that they're better results, that we will not fly you home until we feel you are right to fly home. So just to finish, how would it be in the ideal medical travel world if we could fix all these things? I think clearly we would have better informed patients, patients who were briefed before, during, and after the operation. We would have properly certified hospitals, clinics, and specialists. In many countries, there is no restriction on those hospitals, clinics, and specialists who can manage international patients. And if there are regulations in place, those regulations need to be implemented, and annual reviews need to take place. If there's insurance in place, it needs to be compulsory for international patients, and it needs to be comprehensive with no kind of get-out clauses. And as I pass to Irving, a much better transition of care. The success of any operation is often not down to what happened in the operating theatre. It is down to what happened afterwards. So, Irving, I will pass to you at this point.
Thanks, Keith. So as we've tried to lay out here, the picture is pretty clear that those of us involved in the cross-border trade, the medical tourism markets, the medical travel markets, that the focus has been on generating leads, encouraging patients, consumers, individuals, clients, however you want to label them, encouraging them to move from one location to another location in order to consume services. And sometimes the reasons for that, sometimes the reasons are price. Sometimes the reasons are delays in access in the source location, the waiting lists in the UK, for example, being a good example. And going to price, sometimes the issue is price. The United States being far and away the most expensive healthcare system on the globe, it's often stated, like it's a matter of fact, that it's the price differential that explains why people travel from the United States to Mexico or Costa Rica to consume medical care. Now, Keith and I have done some research in all of these markets that show that that isn't always the case. But the bottom line is that medical travel describes a person, an individual, a human being traveling across a border to consume risky services in another place. And then they are either getting in a bus or getting in a car, or getting in a train, getting in a plane, and going back. At the best, in the best case, the same risk of adverse outcomes, the same risk of complications would apply to those consumers if they stayed put. The same risk. But the travel alone probably adds some risk. And then you add in some other factors, such as Keith described, with unrealistic expectations, hyperbolic, exaggerated claims, situations where, and we're going to cover this in one of the next programs, situations where the risks are not adequately portrayed to the consumer herself at the point of recruiting the consumer. In fact, where the risks are downplayed. So all of these situations put the consumer at greater risk for an untoward outcome. And the untoward outcome isn't just the moral issue of wanting to do right by the consumer. It isn't just the standards issue being consistent across borders. It has to do with the risks up to the individual's life and the individual's well-being. And if you're purely an economic creature, as Keith pointed out pretty compellingly, the risks to brand damage. Your brand is nothing more than the dominant opinion held by your markets about your destination or your hospital name or your clinic's name. So how can we address these? So thank you, Keith. That was terrific. We have a little time for some questions. Emily, do we have some questions?
Hi, we do have one question from your earlier figures, Irving, asking if the figures were global, the numbers.
Good question. Yes, they were. Those numbers are taken from several sources, estimating the size of the overall global markets for the cross-border travel of people to receive medical care. That's secondary and tertiary and quaternary care. And the estimates of people traveling for cosmetic procedures is also using similar standards. So those are global numbers. To many people, those numbers are going to seem small. in part because of the hyperbole, in many cases, unwarranted exaggeration is really the only way to talk about it. Exaggeration of the size of these markets. Many actors, many communicators in the field, in the markets, have sold themselves or sold reports or sold information based on these inflated numbers. These data that I presented are admittedly conservative, and they're based on facts and data points that we're able to confirm through our research around the world. So yes, those are global numbers, and we then took the readmissions rates and the complications rates from both the United States and the UK and applied those to those numbers, assuming no judgment about the competency or effectiveness of the other providers, but just assuming that these are the to be expected complications rates. So do you want to weigh in on this subject, Keith? Do you have an observation about it?
No, I think your kind of numbers are kind of reasonable. As we know, whenever I see a number for the size and the volume in the market on the web, I divide it by 10. We keep our own records. We've kind of monitored the market over years, and it's always much smaller than people promote it to be, I think is my view. Yeah, and I think the point you're making is, even if we assume that the surgeon in Turkey or Croatia or Spain or wherever is just as good, and the hospital is just as good as the one in the UK or the USA, there will be complications. And in medical travel, those expected frequency of complications just isn't managed very well. That's the issue.
Right, and it's not trying to get away from the moralistic message about they should have done, they should have. Yeah. There's no finger wagging here. What I think Keith and I are trying to say is that if a provider or a destination is going to be involved in the business, the transactions associated with the movement of individuals into their location or into their clinics from a foreign location, that there are standards of care for the pre and the post. And that's just not received the level of attention in these markets that's absolutely warranted just based on the evidence that we can cite from the 2 locations that we have immediate access to the data for, the United States and the UK. And the way to do that, the methods for doing that, it's not rocket science. It's not exceedingly complicated. Go ahead.
Sorry, I think it's worth mentioning kind of destinations that are kind of ahead of the game. The 2 that spring to mind for me are Malaysia and South Korea.
Yes.
Malaysia is both very good at delivering an overall patient experience, an end-to-end patient experience, but it does because it has local offices within most of its target markets. It has that aren't just there as marketing activities, that are there to support patients when they return to their source market. I think also there's a question from Zahid Hamid. I just looked at on the. He's talking about Turkey and does Turkey or any medical travel destination care about its reputation? If they did, they would introduce medical negligence and professional indemnity insurance, which is non-existent. Well, Turkey's tried to solve the problem by introducing a regulations scheme, but that clearly hasn't worked. And you can kind of see that from the numbers, because they've certified 2,000 hospitals and clinics. Now, if you go to Malaysia and you ask the Malaysia Healthcare Travel Commission how many hospitals and clinics are within your network that are approved to handle international patients, it's 150, I believe. And that's, you know, there's kind of those two numbers kind of tell you something. You want to handle international patients in a big way in Malaysia, then you're going to be one of 150. In Turkey, you're one of 2,000. How clear is that certification process? The other thing, you know, is when things go wrong. I mean, you know, South Korea, you know, one of the ways they handle it is when things go wrong, they follow it up. So they, you know, there is a complaints process. There is a body set up that if things go wrong with medical tourists, there is somewhere you can go to raise the issue. Their job is to kind of uncover what the issue is and fix it so it doesn't happen again. So things do go wrong. You know, if you haven't got someone there that's going to take up your case and resolve it, then how do you avoid it happening again? And that needs to be in place.
Yes. So I completely agree with that. I think the question or the observation about insurance is critical, and the insurance coverages must cover the care, not just back in the country. Because if I get my hip done in Mexico and I come back and I have a problem with the wound, there might not have been any problem with the surgery itself. It could have been done to a very high standard, but I took a shower before I should have taken a shower, or I did whatever, and my wound got infected. And perhaps I didn't care for that, or perhaps I'm diabetic. And so I have exceedingly difficult wound healing problems. That may not be covered by insurance, but if you can prevent, what the research on Project RED shows is that you can prevent 1 out of 5 of these hospital readmissions. And if you can prevent that by a simple communications protocol between the provider and the patient and the destination provider, then doesn't it make sense to do that? Absolutely. So instead of reaching for the basket and the shovel to clean up the mess afterwards, let's prevent the mess in the first place.
Yeah,
so
I think the other interesting thing out of the, you know, that study that's recently done in the UK on bariatric surgery, what they're saying of those patients who come back, they said 60% of those patients were not appropriate for bariatric surgery. So they did not meet the criteria for bariatric. They could not have got it under the NHS in the UK anyway, because the NHS would not have deemed them appropriate for various reasons to have that surgery. But they went to Turkey, and the Turkish clinic said, yeah, fine, we'll do it.
Right. This is like prescription shopping, right? Yeah. You go to one pharmacist, you're not able to get what you want. You go to another pharmacist and, oh, maybe you can get it there. So I can't get my bariatric surgery in the UK, but maybe if I go to pick a place, Turkey, I can get it there. We encounter this all the time, and we encounter these behaviors in consumers who are attempting to access something that they are committed to psychologically, even though they aren't appropriate for doing it. We see it with cosmetic surgery. People, these individuals with body dysmorphia, don't necessarily have the clinical criteria, but they go and they get the procedures done anyhow. We have a lot of questions here. Can you help us sort through these, Emily?
Yes. First is, do you have any study that shows what is the cost and side effect of not doing necessary treatments abroad in a healthcare system in personal patient health if they do that in the right time?
What do you think that means, Keith?
So let's take orthopedics, hip and knee replacements, where you've got a long waiting list in the UK, and there are Brits, you know, nowadays going abroad for that, which 5-10 years ago they would not have gone. Outbound from the UK, predominantly dental, cosmetic, IVF. So people were going to either get their hip or knee done in the UK, either in the NHS or go private. So what they're saying here is, let's say I need a knee replacement, and I do at the moment, which is interesting. So let's say if I want to have this done on the NHS, I might have to wait a year, 18 months. to have this fixed. If I don't go abroad for it, what's the kind of cost to me, the system, my personal health, if I don't get it fixed? If my only option to get it done now is to go abroad and have it done on the cheap. And there isn't any study that's looked at this, but clearly there's an impact.
Yes, and that would be an interesting, that's an interesting hypothetical, and it would be worthwhile to try to investigate. So whoever posed that question, if you want to be in touch afterwards, Arash, let's be in touch. Maybe there's a way to derive those numbers somehow. I think we have time for a couple more if we're quick. Emily?
Sure. Should the medical travel coordinator be responsible for ensuring that the follow-up care be incorporated in the total package that's being sold to the consumer?
What a good question. So the medical travel coordinator, that's the agent who derives profit from the consumer traveling. If the agent is able to convince the provider to undertake some of the discharge procedures we've outlined, and if the agent has been discriminating in the contracts that she's developed with providers who don't oversell and are very careful and discreet about not treating individuals for whom such treatments are inappropriate, if those kinds of relationships exist, and I know agents who have those relationships, then there's no insurance necessary that's needed. There is rather the encouragement of the provider to be clear with the consumer, and the consumer then to be clear with her providers back home. I think if we're talking about insurance packages, many locations and many hospitals are now adding the cost of insurance to the quoted price to the consumer. And do you want to respond to this question, Keith?
Sorry, say that again, Irving.
So the question came that should the facilitator, should the agent be responsible for the price of the insurance, basically? I think that was the question.
They should be encouraged. It should be part of the package, as they're trying to do in Turkey. So if you buy a package of a bariatric or orthopedic surgery or whatever, that the insurance should be built into every package. And the issue at the moment is the right kind of insurance that fully covers you currently available, and the answer is probably not. And the issue always been with this kind of insurance is it's so very difficult to measure the risk and the cost and put a price on your insurance product.
Right.
It's complicated.
Quick chance. Well, we're at 6, so we should probably stop here out of respect to the group that signed in. Just FYI, if we didn't get to your question here, we're going to make a transcript of the questions and we will respond in kind to them. And Emily, do you want to talk a little bit about the next programs in this series?
Sure. We'd invite everybody to save the dates for our next 3 webinars, which will be one in February, one in March, and one in April. As you can see here, I put the link in the chat for more information and for the registration links.
And with that, we say thank you all. Thank you, Keith, very much for participating in this. Thank you all for being here. And let's continue this conversation because it's an important one. And thank you very much.
Thanks, Irving. Thank you, guys.